The first speaker, Professor Vito Romano from Brescia University. Let me tell you who is that guy. The guy is really nice, from Italy. And Vito will speak about artificial iris today. He is a professor of ophthalmology in Brescia. Also has a honorary position in Liverpool. He's a surgeon talking about translational medicine as well, like clinical trials with cornea. And I think so that is the only guy on the audience who prefer swimming from Sicily to Italy than flying or taking a boat. Vito Romano.
Thank you very much. Thank you very much. Always, it's too kind with me. It's very good friends, as you can see, and yeah, thank you very, very much. So first of all, I would, I think, yeah, you can see. First of all, I would like to thank you for the organization, for the invite. I would like to thank you, Ivana, Nevel, Barbara for the invite, and Neil, not just for the invite, but also for to support all the way from in the cost application. This is the results from cost application. So what there is a group of us that probably you will see in the end that worked on exactly this question. The question was what to do with the patient that develop cataract. We know that the aniridic patient, they have a quite early cataract, and it's a quite good time sometimes to address the photophobia or the light sensitivity, adding an iris. The question was, is this iris, the implantation of the iris, the artificial iris, it's a good idea and help the patient or can cause more problem? So as we, let's see if it works this, perfect. No, okay. As we know, the congenital aniridia is panocular disorder. As you can see, that the percentage of the different kind of the problem that there are in aniridic patient. As you can see, the cataract it's 90%. So it's with the aniridia associated keratopathy is the one of the most important problem that we have it. So of course, altogether cause the problem of the vision, reduction of vision, and all the other issue. The question is the cataract we can address doing cataract surgery, and we try to help the patient exactly doing that. We know that from 50 to 85% there is an indication quite early on. If you want to know, between 25 and 30 years old, they do the cataract. The question, as I said, is with or without prosthetic iris device. Which iris device we have? We have a capsular tension ring device that is quite challenging and difficult for a surgeon to do because it comes in two pieces that you need to address inside of the capsule and inside the capsule bag. And it's not very easy. Sometimes can tear the capsule, and you need to add this segment. There are two segments, one on top of the other, plus the intraocular lens. And it's not easy. I will show you later. Then we have iris lens diaphragm. As you can see, there are two little holes in the optic. This one means that it's not in the bag, but is attached to the periphery, to the sclera. And this means disruption. It's quite destructive. So this you are going to take it out or leave it there, but you need to don't put in the bag. And also require a quite big incision. And we know for this kind of patient, a big incision is not a great option. Then we have a customized artificial iris. There are two kinds. One, there are two different on the market. One that you can put in the bag, and you can have normally it's just the iris, without the lens inside. And then you have the other one that you can attach to the sclera as the other one, but also comes without this optic, and you can put inside of the bag. And you have inside also, you can have with or without intraocular lens. So doing a step back, so we went through the literature and we did research in different kind of electronic database, so PubMed, Scopus, Web of Science, and Cochrane, and we end up to see that excluding the one that have no prosthesis related information article or the one that was not in an aniridic patient, we found just 5 articles, and now we see that these are the 5 articles. They are all retrospective. They have a limited amount of patient, and this is the mean age, as we said, between 20 and 30 years old, and all information they are regarding 2 kind of device that can be iris lens diaphragm, the one that require a big incision, and artificial iris. There are no anyone related to intraocular lens. Intraocular capsule implantation. Other information that you can see, they are all retrospective, and we will go one by one to see what's happened. So if you see the vision and you want to know the vision, I'm sorry regarding probably it's not too big the numbers that you can see, but I will go through. So the first one is the overall improve of visual acuity, and 63% improved the visual acuity. For 27% of the patient was unchanged, and for 10% of the patient the vision worse, so get worse. If you go in details, between the different kind of iris devices, you can see the intra lens, the one that require a big incision, you have a quite big improvement. However, we are not looking at the complication after we see the complication, because there is a big improvement. We know the iris is quite big in these cases, so it's covered for the photosensitivity. And if you do the iris devices, it's a little bit less, it's 58%. There is no information, as I said, regarding the one implantation in the bag. So combined with the cataract, in 97% of the cases, pre-existing keratopathy in 69% of cases, a pre-existing glaucoma in this cohort, 27%. This, of course, can be a confounding factor, and so our analysis, so this number could be not completely right, because we need to take in account of this confounding factor. Other things that we need to take in account, that not in all the paper were information regarding all the possible abnormality that can be in an aniridic patient. And another information, we want to know if this stability was just if this improvement of vision was stable. As you can see, was the best, 75%, so improved the 2 line, 75%, but if you see the last follow-up was just 58% improve of the 2 line. So these results can be not stable. If you want to see the complication, let's look at glare and photophobia. And you can see there was a reduction, is quite big for overall, but if you go iris lens diaphragm or artificial iris, probably the best one was the artificial iris. So there was some glare, improved vision, as you remember before, was very good in ILD, but the glare was not the best. There are missing information here about binocular and monocular vision, improvement of quality of life, or contrast sensitivity. So this is missing in the literature. Other information regarding complication, here is the most important things that probably speaking with the patient with aniridia, of course, there is always this discussion, let's do the cataract or not doing the cataract surgery. Because doing the cataract surgery, we know that people can get a progression of glaucoma, at least in this cohort, of 58%, so it's quite significant. Or there is a progression of aniridic, of keratopathy on 27%, decentration 10%, and endothelial cell loss on 9%. So there is this complication that happened after the surgery in this cohort. So this means we need to understand the balance between doing the surgery and not doing the surgery. Sometimes it's quite challenging because the patient, of course, push for the surgery, but we need to balance and explain to the patient that sometimes you can also have a glaucoma, in 27%, so a new problem that before was no glaucoma. So on this court, 53% after the surgery require glaucoma surgery. That is something in addition. So if you require glaucoma surgery, that means you are going to impair the ocular surface, and we know in this kind of patient can be a little bit challenged. And also corneal transplant instead was not present, was 0%. So we did a quality assessment, and we did also a risk bias. As you can see, the overall was low, the quality was low. Why? Because there was no information, there is a lot of bias, there are no information regarding the other comorbidity, there is no a control, so patients that were not treated. So this we give you a overall not good quality of the analysis. I'm showing now a patient that I treat, and so after doing all this research, I try to improve the outcome. And see, this is a patient with aniridia. Patient with aniridia with a cataract. It's quite young. It's around 35 years old, and the patient that really want to do the cataract surgery and was a significant cataract. This picture is so good because it was under the in the theater, because sometimes it is very difficult to imagine patient at a slit lamp because it's photophobic. And of course the patient was in general anesthesia and under GA, and was possible to do this kind of a picture. The quite good tool that we have is anterior segment OCT. Anterior segment OCT is quite good for two reasons. One, it's not difficult to perform because the light is not so bright as the slit lamp, but give you the opportunity to study 360 degree, because there is no iris, the capsular support and the capsular length. And this is quite good for planning. As you can see, I show this one is 90 degree, and this one is 180. You see exactly where is the fiber, and you see exactly how big is your bag. And this is important. Why? Because you want to plan very well your cataract surgery and your iris implant. So my aim was to do an artificial iris with the lens, including the lens inside, and customize for the size of the bag. So I think it's I showed the video. Sorry if someone doesn't like it, but lasts not too long. If hope that I will show the implantation. So let's see if it works. Yes. So this is the implantation. So you try to minimize. Seems that I squeeze a little bit, but try to minimize the entrance. And I did the cataract. We did the cataract, and you see the implantation here. And you go inside with the iris inside the bag, and then you put the other one in. As you can see now that. I did this one exactly. Now you will see in collaboration with other colleague that is also quite expert on this, and you will see that you put the first one, then you put the second one in. What you notice here, that I show you probably better, that is not complete. So of course there is this part that is not great, but the aim was to optimize. You will see better here. You will see better here to optimize the. So don't leave the anatomy as it is. And of course, here we are out of the bag, but we try to see if this thing could improve, avoid, all the complications that we had before. Probably it's not the best in terms of, cover everything in terms of light, but it's something to minimize the complication and improve your outcome. Other things that you need to think about when you do this kind of surgery is to minimize the intraocular lens. So intraocular pressure when you do the cataract surgery, because of course this you don't want to make any further pressure on the periphery. And you can see that this is 180 degree. This is This is a 90 degree. So with OCT, you can study really 360 degree. And you can see the size, if you compare before and after, this is exactly the distance. And if this distance make it easier also for your implantation. This lens has built inside a lens inside. You can have with and without. Probably if I need to tell you, the better is without. So you put before the lens in, and then you put, because with lens, it's a little bit more challenge without. So in the end, the challenge that we can optimize is a high rate of preoperative comorbidity that probably the people that do the research on it, we should mention always the comorbidity present. The high postoperative complication. For this reason, we need to speak with the patient and discuss with them. We know that probably, I think I need to say that after with the Chiara Ancona, we are working on narrative medicine. And narrative medicine give sometimes a different, so you listen the story of the patient and you try to help them from different point of view. And you need to, spend time with the patient. This is the most important things. Low prevalence of the disease and low quality evidence at the moment. So I would like to thank you exactly Neil, Miriam Barbagni, this and yeah, okay? This is just to make sure. Laura, Klaus, and Dominique. Thank you so much.
Thank you, Vito. It was a great talk. And maybe because it's a little bit a different topic, then we can discuss now. Galina, please.
Thank you very much. Like looking at the very big number of patients, it's like more than 600. We have some kids who has mutation not in PAX6 itself, but it's like in nearest region. So these kids, they don't have macular hypoplasia, they have very good optic nerve, and they just don't have iris. So these kids can see 90–80%. So it's like the meaning, what I want to say, the iris itself doesn't really affect the vision. So I think it should be more deeply analyzed, like in a really proper way. But my idea is maybe these kids who has no mutation in PAX6, but they have this specific mutation, I cannot remember the name now, maybe geneticists, they know better. We call it like close to PAX6 region, which is like brilliant macula, brilliant optic nerve, just missing the iris. Maybe they are candidates for this type of surgery. So in my way, in my opinion, this kind of surgery should be more deeply studied in the way of genetic test analysis. And then if we specify those kids, like this is, for example, can be very heavy case, like a nonsense mutation or whatever. And this is this light case, which is close to PAX6 region, which is very good in macula, and as I said, optic nerve, and no keratopathy. So maybe these kids, they are candidates. But if we will do this in a normal eye, knowing that macula not developed, so if you put iris, if you don't put iris, macula still not developed. So their vision cannot be better in a big number. Know what I want to say? So.
I think it's a very good point. This exactly was the point that we have to pay accord to the patient. We need to really look deeply and characterize better to have a better conclusion. At the moment, at least we in Brescia, we do a genetic analysis. We try to see if there is PAX6. If there is not, cornea involvement for this patient, probably the first step is to have an approach that is less invasive, with the contact lens, if there is no keratopathy, no ocular surface disease, and we'll see there is really an improvement. And then, of course, study this patient and try probably an approach that could be non-surgical or surgical. Probably the results will be much different and probably better.
No, like in the early stage, there is no keratopathy, but keratopathy will come. So this is why we all, like Dr. Nela Gali and Barbara Kessman, they always were saying, we start to do prophylactic from stage 0 when they're like newborn babies, like dexpanthenol, heparin, and all this stuff. to keep the cornea in a healthy stage. So maybe, as I said again, it's very deeply should be studied genetic based, just to divide all these kids who don't have a real mutation in PAC6 with a good macula, good optic nerve, and then they are candidates. So this is like more. Thank you.
I think you're pretty right about this, but you know, my experience is that we have collected now over 400 patients with aniridia in Poland, and we have not even 5% genetics of them. This is a problem. A lot of them is coming, you know, in really advanced stages, because we are this referral university for this kind of patient, and they have advanced cataract. Last year I did over 10 cataract surgery in aniridia, and all of them was like hand movement, visual acuity. And then there is a question, another question is because this kind of surgery, which we're talking with Vito, it's not, there is no refundable from the government in Poland. So it's another problem. And from last year, patients, I did the surgery, nobody could afford that. We tried to get money from the foundation, some others, but it's another problem. And you know, my opinion is that first of all, save the back, because if you're doing that kind of surgery, you need to be really experienced, because it's really hard surgery. And I'm doing personally quite not so narrow capsulorhexis, and most of these patients improving phimosis, which is like an artificial iris, and putting just one piece IOL, and it's quite good results. Of course, the anuritic keratopathy is a big problem also during the surgery, because we cannot see properly everything, so that's the point. And I don't remember even I was doing the cataract surgery in patient with clear cornea, because always the bigger problem is advanced keratopathy and all these things we are talking about.
Should be operated if it's like destroying the visual activity. So cataract, this is like, what can we do? We have to operate cataract. But putting some extra, like artificial iris, which is quite big implant. So this is the question for this, what I said, very deep genetic analysis. But cataract, absolutely agree with you. Like, do you do your best just because you keep the vision in the best possible way? It's like very challenging. Choosing between, but sometimes cataract just close all the nearest vision, and this is only way. So yeah, so this
I think exactly. The discussion with the patient is very important, because in addition to this information, we are doing always a cataract in a young patient. A young patient means if you try to explain, so you are going to remove a volume that is quite big from inside of the eye. We know inside the eye there is something called vitreous, that is a gel. So this gel can move forward and cause some damage in the back of the eye. Compared to the volume with this volume is much less. So that is the reason there is a movement forward of the vitreous. So we need to always speak with the patient, balance which are the pros and cons, and try to address this thing try to minimize the risk, of course. But characterization, as all the others, not just clinically, as we said, but also genetic, is very important, as you said, because could be the difference that make your change in the path. Thanks.
Thank you for a good discussion, good questions. Thank you, Vito.